Thing we're going to talk about this week are Q waves, and we should pay attention to Q waves because sometimes they're significant, sometimes they're not significant, sometimes they're normal, sometimes they're not so normal. So let's get into Q waves briefly. When looking at Q waves, we're going to call them significant or insignificant, or physiologic or pathologic. Just like your left axis deviation can be physiologic or pathologic, so can your Q waves. So physiologic is normal, everyday thing. I was born with it. It's cool. Pathologic, it's bad. Something happened to cause this. So our significant Q waves, our pathologic Q waves, mean that our patient had an MI in that region in the past. So your patient might say, I don't have any cardiac history. And then you take a 12 lead and you see this pathologic significant Q wave, and you go, you know what, boo boo? You had a heart attack. Maybe you didn't go to the hospital. Maybe you had a little bit of chest pressure, a little bit of chest pain, but you just kind of slept it off, ignored it. You had a heart attack. Somewhere, somehow. So these significant pathologic Q waves tell us a lot about our patient's cardiac history. So what makes a significant pathologic Q wave? Well, if it's more than 1/3 the total height of the QRS complex itself, it's significant. If it's wider than 0.03 seconds, it's significant. Please don't try to measure 0.03 seconds. If it's one tiny little box or wider, it is significant. If the water test, water bucket test, if you poured a bucket of water over this QRS complex, would that Q wave hold any water? If it does, it is significant. For a couple examples, we're just looking at the limb leads, two separate 12 leads on either side. We have what we're going to call septal Q waves, insignificant Q waves, physiologic Q waves here on the left, pathologic Q waves here on the right. So our physiologic Q waves, not wide enough, not deep enough. Our pathologic Q waves, deep enough and or wide enough. So if it's super deep and or super wide, it is a pathologic Q wave. Something happened. They had a heart attack. There was some damage in that region of the heart. Also dealing with Q waves, just want to mention briefly that there is some respiratory variation in some patients. So obese patients, pregnant patients, patients with significant ascites, anything in which the abdomen is kind of pushing up on the heart. There's this respiratory variation where the Q wave gets deeper, then returns to kind of its normal state. And we're looking at lead 2, lead 3, and the Q wave gets deeper, then not so deep, then deeper, then not so deep, then deeper, then not so deep while your patient is breathing. This is because all that pressure from the abdomen is actually kind of shifting, pushing, physically pushing the heart and changing kind of its axis in the physical axis in your patient's chest. So we expire. As your patient expires, we get a deep Q wave. As they inspire, Q wave gets smaller and smaller and smaller. So if you're, just looking at your monitor, you've got a larger patient, or pregnant patient, or obese patient, or a patient with ascites, some sort of abdominal pressure, you might see this this Q wave variation, and that's nothing going on with the heart, the conduction itself, or the condition of the heart itself. That's just the heart being physically moved within the chest. If you have any questions about all of this stuff, left ventricular hypertrophy, right ventricular hypertrophy, Q waves, everything else, bundle branch blocks with hypertrophy, please, please, please let me know.